Hello everyone. This is Julie. Welcome to COXO webinar again. This time, we really very thanks to invite our Professor Dr. Kelly from Philippines, and then to join with our webinar. I think our old COXO friend all know COXO every week we try to make the free public webinar for our dentist friend to study more technology, and then this time we special to talking about the endodontic irrigation like this one. Okay, before we make the close, first let us to be know the regulation again. For our COXO webinar, we will prepare a certificate for all our dentist friends. So after the course, at the nearby at the end of the course, we will send a link for everyone to fill the certificate. So let me check how to get the certificate. Okay, you can see this is our certificate regulation. First, you need to like our COXO Facebook, and then you can. Second is you need to comment in this link. During this webinar, you can comment such as some question you want to ask of our Dr. Kelly. Then you can leave some question, and then after the course, we will answer the question. At the end, we will give you a link to fill your information like your full name, email address like that. To within 5 days, I will give you the PDF certificate. So if you need certificate, please remember to fill the link for us. And then after the course, at the end of the course, pay attention. This is the most I think many dentists interesting about. We have a lucky draw. This time, a special to make a prize to make from our company to get the lucky draw is 5 pieces end of five pieces. So this is a very good end of file. Later I will introduce. Then this time we really very thank you for our Philippine dealer Raquel to support our COXO. So let me introduce our good dealer Raquel from Philippines to come online. Hello, Joanne.
Hi, good afternoon, everyone. Yeah,
Yeah,
welcome to our webinar today.
yeah. I think your first time to join with us our webinar. So
Yeah,
now you
it's
can
first
take
time.
time to introduce of your company for our Philippine friends.
Okay, thank you, Jolly. Good afternoon, distinguished guests. My name is Joanne King. I am the president of Value Dent Dental Corporation. Our company has been in the dental industry for almost 40 years. My parents opened New Victory Dental Supply in
Joanne, I
1981.
think you need to share, play your PowerPoint.
Yeah, sorry, in 1981. We are a retail outlet in Quiapo, Manila, Philippines. And sorry, share screen. Can you see it?
I can see your screen. Then you can turn on your
Sorry.
PowerPoint to full screen. Yeah.
Yeah, here.
Okay.
Sorry. Yeah. Yeah, we started in 1981 as a retail store in Quiapo, Manila, Philippines. And we cater to different dentists, dental technicians, and students in Metro Manila. I joined the company in after finishing university and have expanded our operations all over the Philippines. We renamed our company to Value Dent Dental Corporation 5 years ago. We take pride in providing quality products in affordable prices and the highest level of customer service. We know that dentists have busy schedules, and by being a one stop shop for all their dental needs, we let them concentrate on their practice. We carry many global brands of dental products that are of highest quality and are always on the lookout for new and quality products for our clients. Here are the brands that we carry. And of course, our latest partnership is with COXO. COXO is a leading manufacturer of dental equipment in China. We are proud to be offering COXO products to you, our valued clients. Today, we have offer some promotions for the Black Friday sale as part of our webinar. We will be giving promotions for several equipments, as you can see in the screen. And then, because you have joined the webinar, you can also feel free to comment on our site for some questions so we could know that you attended the seminar, and you can get a raffle prize and also get the promotional discount. So, our speaker for today is Dr. Kelly Yangco. I will be introducing her now. Um, Dr. Kelly Yangco, oops, sorry.
So many promotion. Black Friday,
Sorry.
right?
Yeah.
Okay, let me
Dr.
introduce
Kelly
you.
Yangco is from the University of the Philippines. She studied she graduated in 1999. In year 2000, Dr. Kelly went to an externship program for oral surgery in the University of the Philippines, PGH, Manila. In 2003, Dr. Kelly went to an internship program in hospital dentistry at St. Jude Hospital. And then she went on a certificate program in 2008 at St. Jude Hospital. Yeah. And then in 2013, Doc Kelly went into an entrepreneurship program at Asian Institute of Management in Makati. Currently, Doc Kelly is finishing her studies in advances in dental implant and periodontics in the University of College of Dentistry at New York University. She also conducted several lectures and workshops for endodontics and hospital dentistry. She is currently the owner of Tooth Options Dental Clinic. Let us all welcome Dr. Kelly Yangco.
Okay, welcome. Hello, Dr.
Hello.
Kelly.
Hi.
Hello.
Hi, everyone.
Yeah, how are you?
I'm good. Can you see me? Not yet.
Yeah, I can see you.
Hello. Hello, everyone. So, should we start the webinar already? So, should we start the course?
Yeah, maybe we want to know about now in Philippines the situation of COVID-19 for dentists. How about the situation now?
Oh, situation is okay. We're opening up now slowly, but we have our most of the dental clinics have opened since June 2020. So as frontliners, the government of the Philippines allowed us to operate already.
So you already get the vaccine. I think in most of them in Philippines is that get the vaccine to protect.
Yes, yes.
Yeah, that's good. In China, the same now already I already inject about 3 times.
Oh yeah.
Yeah,
Okay.
this is more safe. I see the situation maybe in China still need to waiting for about 1 year. Then we can meet you. Then I
Yes,
can
yes.
invite
I hope
every our
I
dentist
miss
friend
visiting
come
to
China.
your to China and your office. So it would be
Yeah,
great
cause
if we could go there again.
Our COXO make a new factory next year. So I hope
Oh
next year
wow.
all our dentist friend can come to our COXO factory open day again to visit our
Mm-hmm.
COXO new factory, and we will make out the first one dental museum in China.
Oh
So next
wow.
time if you visit our COXO, then you will see very big museum to know the dentist about the dental history. Maybe more than 100 years ago, the equipment, the same you can see in our culture.
Oh wow. Oh, that's really
Yeah,
good
this
of
is
COXO to do
interesting.
that.
Yeah. Okay, so
Yeah.
now it's time for Dr. Kenny to make the webinar.
All right. Thank
Okay.
you, Jolly. Thank you, Joanne, for the introduction. So I'd like to say hi to everyone. Thank you for being here and spending your precious time with us today. And as I understand, this webinar is global. So I would like to say that I hope that you are safe wherever you are in the world and you continue to be safe. And I'd like to thank COXO for giving me the opportunity to do this presentation for you. So we would start with our topic for today would be the commonly used endodontic irrigants and medicaments. So this presentation would be like watching an old movie that you have already seen, but you have forgotten some parts already. So I hope that with this listening to this presentation would benefit you later on in your endodontic practice. So let me start by saying that let me introduce myself. My name is Dr. Raquel Yangco. My friends and my patients and colleague as well, they call me Dr. Kelly. My practice is located in Makati, Philippines, which is a central business district. I have my practice is also a multidisciplinary one. We accept general procedures done by my dental associates. Most of the cases I do are endodontic cases, implant placement, and restorations of implants. So learning objectives for today will be touching or briefly reviewing the root canal anatomy, which is very complex. We would also be discussing commonly used irrigants in endodontics, along with techniques and devices to improve your game in irrigation. And also, I will be also briefly touching your commonly used intracanal medicaments in endodontics. So the main steps in the treatment of teeth with pulpal and periapical disease, as we know, would be your diagnosis, your instrumentation, your obturation, and restoration. So your diagnosis would involve your periapical X-rays, along with your pulp test and cold test, and you correlate it with your radiographs. And of course, your CBCTs, with the advent of the CBCT scans, we are now able to view our cases in a 3D manner. Your instrumentation, which is a biomechanical part of your endodontic treatment, it would involve your traditional files, your use of various rotary instruments, which is, by the way, it's around already 200. There are already 200 file systems available in the market today. So the Apex locators would also help us. And also, with the introduction of the operating microscope, our visibility is really enhanced as of the moment. So your obturation would involve your lateral condensation, whichever you want, your single cone technique, and your warm vertical compaction. And also, part of your endodontic would be the proper restoration using your onlays, which is now preferred by our friends and colleagues who does biomimetic dentistry. And of course, your traditional post and crowns. So with endodontic therapy, we aim to do a total elimination of vital and necrotic pulp tissues. We would also aim to kill residual microorganisms along with its toxins and byproducts found in the infected canal. We would also want to render an effective seal in order to prevent recolonization of your root canal system with bacteria. So this slide would show you different photos. The first one would be from Dr. Walter Hess. He was the first one who published in 1917, and he tried to show us how complex the root canal anatomy is. So the second and third would be the more recent photographs. The second one would be a micro-city done by students from Brazil. And the third one would be a CBCT eggshell section of different anatomies of our teeth. As you can see, like from 1917, there's no difference. Apparently, we haven't evolved yet, so you can still see the complexity of the root canal, which would involve your ramifications and your lateral fins and deltas. So okay, so let us focus on the second photo. The apical third would show us where the most of the ramifications are. So when we're doing our apical surgery, when we remove 1 millimeter during apical root end resection, we remove 52% of the ramifications. If we remove 2 millimeters, we would be removing 78% of the ramifications. And if we remove 3 millimeters of the root end of our resection, we would be able to eliminate 98% of the ramifications. That's why in Cohen they would advocate the removal of at least 3 millimeters during apical surgery. So we have major obstacles aside from the root canal, from the complexity of the root canal system. It would involve the microscopic examinations would show that there are irregular complexes with many cul-de-sacs. We have fins, as I said before, lateral canals and ramifications and deltas. Aside from this, we have to deal with other obstacles such as your dentinal tubules and then invasion of the dentinal tubules by microorganism, instrumentation of your smear layer during your instrumentation, and of course the presence of dentin as a tissue. So this photo would show, this is from Dr. Marco Vershani. By the way, he has a website that would show such micro cities, and this one would show the green area would show that the natural root canal anatomy or the complex root canal anatomy. The red one would show the area that is touched by your instruments during your instrumentation, your rotary files or hand files. So this would show that approximately only 40 to 60%, 40 to 60% of your root canal anatomy cannot be cleaned alone by instrumentation, even if you use your rotary or reciprocating systems. Regardless of the canal preparation system, the anatomical complexity of the root canal system, it makes it difficult to completely clean and disinfect it. So here is another photo of a lower mesial root of a molar. So the red arrow would show that the isthmuses were not properly cleaned, and the yellow arrows would show the accumulation of debris, which was left by your instrumentation. This area should have been occupied by root canal sealer. Thus, I think that's why this root canal treatment failed. So with endodontic cleaning, there are two types. There are two tiers or two ladders. First one would be your mechanical, which would involve your access burrs, your files, your rotary night eye file system, and your ultrasonic instruments. The second one would be your chemical irrigants. So instrumentation serves to clear, very important. It serves to clear the pathway for effective irrigation by removing debris while maintaining the natural anatomy of the root canal system. Our success rate increases as we improve the irrigation protocols. And by the way, according to Dr. Cunha, he said specifically that there is already a paradigm shift with endodontic cleaning. He said that root canal treatment begins once you are finished with your mechanical cleaning or your instrumentation. So I looked up the definition of irrigation from Google. So it is apparently the process of washing out an organ or wound with continuous flow of water or medication. So for many years, irrigation has been used in conjunction with endodontic therapy. One of the most important reasons why we irrigate the root canal system is to keep the canals clean prior to our obturation procedure. So irrigation enables us to remove the microorganisms and organic matter left by your instrumentation. So there are ideal properties of our irrigants that we would want when we choose them. So to effectively clean and disinfect the root canal system, an irrigant should be able to disinfect and penetrate the dentine and its dentinal tubules. You would want it to offer a long-term antibacterial effect, which is our substantivity. You would want it to have this effect of the removal of the smear layer. It should be non-antigenic, meaning it should not start an immune response from our patient, and we would want it to be low in toxicity as well. And it should not have no it shouldn't have an adverse effect on dentine and the sealing ability of the filling materials. Other properties of an ideal irrigant would be the ease of application. We would want it to be easy. We would want it a material that is easy to handle or manipulate. It should offer no staining, and we want it to be not too expensive because later on I will discuss that using a large volume of irrigant is required to do a proper irrigant protocol. We would want it to be also be able to dissolve necrotic and vital pulp tissues, and we would want it to be able to inactivate endotoxins as well. Though surface tension is one property that we would want in an irrigant, and we would want it to help us during instrumentation by lubricating the canals also. So sterilization and disinfection action is also very important. So we come to this point wherein we would talk about the very famous sodium hypochlorite, which we use every day. I think this is the gold standard for irrigants. We have been using this for almost 1 century. Historically, it was used as a Dakin solution in World War I, And during those times, they use it to irrigate the wounds of soldiers. It is available in the market in zero point 0.5 to 5.25%, but I heard from recent seminars that they are using it in 6% already. So it's up to the practitioner which concentrations they want. It is available as a household bleach. This is our common household bleach, or available as a clinical grade. So one of the advantages of sodium hypochlorite is that it is very affordable. So sodium hypochlorite has been demonstrated to be an effective agent against a broad spectrum of bacteria, and it can dissolve vital as well as necrotic tissues as well. Um, it has been shown to also to be sporicidal and virucidal. So sodium hypochlorite has shown to be have more effect on necrotic tissue than on vital tissue. So mode of action, the mechanism of action of sodium hypochlorite is that the free chlorine dissolves. Free chlorine dissolves the vital tissue and the necrotic tissue by breaking down the proteins into amino acids. So with sodium hypochlorite, we have to know that when you decrease the concentration, good thing is it decreases the toxicity, but then along with it, you decrease its antibacterial effect and also the ability to dissolve tissue. With the volume, when it comes to volume, you increase the effectivity if you irrigate your root canal system with large amounts of sodium hypochlorite. Another tip that we could get would be your increase in temperature. So warming your sodium hypochlorite to 50 to 60 degrees centigrade would significantly increase the rate and effectiveness of tissue dissolution and removal of smear layer. Although sodium hypochlorite is almost an ideal irrigant, it has its own disadvantages such as cytotoxicity. It has foul odor and taste, so sometimes the patient will say they smell laundry when we are doing our root canal treatment. It has the ability to discolor clothes as well, so we have to be careful in staining, especially if our patients wear expensive clothing. We don't want to pay for it. It also Sodium hypochlorite has ability to erode metal objects as well. One of the things that one of the major disadvantages of sodium hypochlorite, but is that it cannot its inability to remove the smear layer. But later on, we will discuss and how do we deal with it. Another thing is that it does not kill all bacteria, including E. faecalis, which is the culprit, which is the bacteria involved in persistent periapical lesions. And sodium hypochlorite also can alter the property of dentine. So for proper antimicrobial activity, we have to freshly prepare sodium hypochlorite daily, or better if it's prior to your procedure. We have to know that exposure to light, oxygen, and regular room temperature can cause its inactivation. An example, I just want to give you an example of mixing sodium hypochlorite. For example, you would use 1 cup of sodium hypochlorite along with 1 cup of 1 volume of saline solution. It would yield to the 1/2 concentration. So meaning if we dilute 5.25% of sodium hypochlorite with of 1 cup of sodium hypochlorite with 1 cup of saline solution, we would yield with a concentration of 2.5 to 2.6 percent concentration. So it's up to you where you're comfortable, the concentration that you are comfortable to use in with your patients. So as I said, sodium hypochlorite is almost an ideal irrigant, but there is what we call the extrusion of this irrigant into the periapical soft tissue, which we call the sodium hypochlorite accident. So we must be able to identify it immediately. The patient would be experiencing an excruciating pain for 2 to 5 minutes. There would be an immediate swelling or ballooning on the involved area. Profuse bleeding, you would see also interstitially, meaning along the skin near the area of the accident. And also it could manifest inside the tooth intraorally, where you would have profuse bleeding inside the tooth. Okay, so the diagnosis is very important. We have to know also that sodium hypochlorite is usually associated with pulp necrosis with periapical radiolucencies. It was also known to be more associated with maxillary teeth than on mandibular teeth, and it is more common in posterior teeth than in anterior teeth. So, what are the possible causes of sodium hypochlorite accident? So, it could be a indirect working length determination. It could be iatrogenic, meaning we inadvertently widen the periapical foramen, or one reason would be to using a really big gauge needle that would wedge into the root canal system. So, here's an example of a sodium hypochlorite accident. On day two, you would see that there is bruising near the periorbital area, and then even on day seven, palatal necrosis or partial palatal necrosis is still apparent. Day 30, you would have some significant improvement, but still some bruising is still apparent in the in the periorbital region. So treatment, I would suggest that if you experience this, the reassurance is on the end, but you have to keep yourself composed and do not panic. It's dealing with the sodium hypochlorite accident is not easy, but you have to be relaxed when you're doing this, because you don't want your patient to be nervous. At the time, for sure, your patient will be experiencing, as I said, excruciating pain. So what we can do is to rinse it thoroughly with saline or water. You can apply cold compress on the involved area. Pain control and analgesics would great helpfully. And you can prescribe antibiotics such as amoxicillin to prevent any secondary infection. And the most important is the assurance of the patient, because sometimes these types of accident can invite a lawsuit. So we have to be very caring and reassuring to our patients. Prevention of sodium hypochlorite accident would involve needle positions short of the working length. That's why when I do my irrigation, I usually use a rubber stopper. Should be short of the working length of 1 to 2 millimeters. Try to use a small gauge needle. It should loosely fit in the root canal. During irrigation, movement of the root canal of your syringe of 2 millimeters, 2 to 3 millimeters amplitude would help avoid wedging into the canal. And use of side vented needles would also help. And you have to control the flow of the solution. So using a small gauge needle would help this. Plus, if you use your thumb with expressing the sodium hypochlorite, that could greatly help, but it would take some practice. All right. So self irrigation. So in choosing your irrigating needles, one should put in mind the safety of maintaining the distance of the periapical region, but you should still remain. But the periapical pressure should still remain. So various needles are available in the market. So you would see that needles A, B, and C would have that periapical pressure, and then the D, E, and F are the side vented needles, which wouldn't have any periapical pressure. But my in my opinion, if you're just using an regular irrigation syringe for your irrigation, I would suggest that you would use the letter C, open end side vented needle. So at least you would have some periapical pressure, but you would have to keep it short of the working length to be safe. So although sodium hypochlorite is the most widely used endodontic irrigant, it has some disadvantages, as I said, that it cannot remove uh, completely remove the organic part. Okay, so it cannot prevent smear layer formation also. So that's when we use the EDTA, or the ethylene diamine tetraacetic acid. So it is a chelating agent. It can remove inorganic portion of the smear layer. So what does it mean? What is the significance of this one? When we remove the smear layer, dentine permeability is increased. Thus, there is reduction of micro leakage later on when we do our root canal filling. So there is like a better bond or a better relationship between your root canal filling and your root canal wall. So this one also increases the ability of the root canal sealer to penetrate the dentinal tubules. That thus it improves the adaptation of the filling of the root canal wall. Another one would be keeping the dentinal tubules open would increase the activity of the endodontic medicaments that we would use. So protocol for this would be 1 minute irrigation of EDTA and then followed by your final rinse of sodium hypochlorite. By the way, the longer the exposure, uh, you increase the possibility of the excessive removal of both peritubular and intratubular dentine. So here is just a photo showing scanning micrograph. So your sodium hypochlorite is, by the way, available in two preparations. One is 17% and one is 19%. So the 17% we use it for our irrigation. 19% is the cream or the gel type, and we use it for calcifications. So this one would show that there is not so much difference between the 17 that the two preparations. So but they would have their own indications for you. So the other one would be for your irrigation, the other one for use for during your instrumentation when you encounter calcifications. So other properties of EDTA that we want is that it's able to detach biofilms from the root canal walls, although EDTA has a very limited antiseptic property. Other chelates that we can use would be your citric acid, your EDTAC, or your MTAD. Another irrigant that we can use would be your chlorhexidine. So chlorhexidine gluconate has been used for the past 50 years for caries prevention in periodontal therapy, wherein we would use it at point 12 and 0.2%. And it has been recommended as an root canal irrigant because of its properties. It is a broad spectrum antibacterial. It has a broad spectrum antibacterial action. It has a longer lasting effect, which is substantivity. That's why sometimes when we ask our patients to gargle with it, we say that, like, please do not rinse with water, or try not to eat anything for 30 minutes after you gargle with it because of the substantivity. It is apparently there are tests or studies that indicated that chlorhexidine does limit E. faecalis adhesion to dentine. As I said earlier, E. faecalis is the culprit or the main bacteria involved with persistent periapical lesions. So chlorhexidine is also low in toxicity, and unlike sodium hypochlorite, it has no foul odor or taste. One of the setbacks of chlorhexidine would be it was unable to remove smear layer. It is also unable to kill all bacteria, and it doesn't dissolve pulp tissues. So here is just a summary of what we talked about. I didn't discuss MTAD anymore because it is not commonly used. So with this, we have to, using different types of irrigants, we have to be aware of the possible interactions. So sodium hypochlorite, mixture of sodium hypochlorite in your EDTA, you have to bear in mind that it reduces the antibacterial and effect and the dissolving properties of your sodium hypochlorite. It could also cause dentine erosion. So if you're not very comfortable with mixing this, what we can do is rinse with saline solution in between the two irrigants. Another one would be your chlorhexidine mixing with EDTA. There would be a white precipitate, formation of a white precipitate, which could add to our debris later on. Another interaction that is very important is the mixture of sodium hypochlorite and chlorhexidine. Mixing this would form a orange-brown precipitate, which we would call the para-chloroaniline (PCA), which is very carcinogenic. So clinically, we would see this like a pink or like a orange stain, which is very hard to remove clinically. So irrigation techniques and devices. This we would discuss to like give us tips on how to improve our irrigation game. So one of the common one or simple ways to improve our irrigation would be heating of the sodium hypochlorite solution with you can use your a regular composite warmer, your composite warmer or a warm water bath. So high temperatures increase in sodium hypochlorite positively increases its antibacterial reaction and its ability to dissolve tissue. So we would want to heat it to 50 to 60 degrees centigrade. Another way of heating your sodium hypochlorite would be intracanal heating. I'm not very comfortable with this, but I'm still going to discuss this so that we know that some people, some practitioners, they do this. You can use your gutta percha cutter, the warm gutta percha cutter, and at 180 degrees. So this one would heat it up, but we have to be very careful because heating it up more than 47 degrees could cause a possible damage on your periodontal ligament. So the most simple way of improving your irrigation technique would be your use of your syringe, no? But you can improve it with agitation using your gutta percha cone, your carrier, your finger spreader, or your cave file. So you can some practitioners they also use endo brushes. So this movement can cause a sufficient hydrodynamic movement inside the canal. It doesn't increase the chemical reaction, but agitation will just increase the surface area being contacted by your irrigants. So also with your agitation, it could minimize the vapor lock effect. So what is the vapor lock effect? The vapor lock effect is the formation of gas bubbles inside the canal, especially in the apical third. It is caused by the dissolution of your pulp tissues, organic residues by your sodium hypochlorite, thus reducing the penetration of an irrigant and so blocking their interaction with the canal walls. They also inhibit their antimicrobial activity and digestive activities. So using a mechanical activation by moving the irrigant solution in the canal can reduce this effect. So active irrigation. So now we go to the equipments that we can use to improve our irrigation. So first one would be your sonic activator. So sonic activation, which is your endo activator. It produces sonic vibration inside the canal, which can go up to the 10,000 RPM or 60 hertz. It hydrodynamically agitates the intracanal ligament. The way this one comes with three sizes. I think it's 20, 25, and 30. So it depends on your canal preparation. So you usually place it 1 to 2 millimeters short of the working length. And during instrumentation, you can use it also to activate the irrigant in between your files. Excuse me. So your sonic activator can be used, as I said, for debridement. It also helps in the smear layer removal and biofilm removal. Other uses of this device would be you can use it because of its very tiny tip. You can use it to adapt and remove calcium hydroxide. Also use it for your MTA, application of MTA. And during retreatment, we can also use it for the removal of the residual obturation material. So now we go to the other one, which is the passive ultrasonic irrigation. So amongst the means of agitation of the chemical substance, ultrasonic irrigation or PUI is the most popular and widely used. So the mechanism of action of this one would be the cavitation effect by producing bubbles that rupture close to the dentin walls. In addition to the formation of the microacoustic current that promotes hydrodynamic movement or agitation in the liquid inside the canal. So this video would show your would compare your sonic activation with ultrasonic activation. As you can see, sonic activation is very gentle. It seems like the movement of the needle is almost like a rotating movement. As compared to our ultrasonic, which is like more intense movement. And this is what it does inside your canals. Another video that I would want to show you is clinically how to use this passive ultrasonic irrigation system. So the LED attached to this device would help us with our visibility during the procedure. And as you can see, I used a rubber stopper to make sure that I'm like 1 to 2 millimeters short of the periapical constriction. And I move it up and down. So this one, you activate it and it automatically stops after 20 seconds. But I usually use it for 30 to 60 seconds per irrigation cycle. Another video would be this one. It would show the effect on the debris on the periapical region of your root canal. Although this is just a tubular clear glass, but I hope it is enough to show us what it does to the debris. So okay, after the shaping of the root canal, cleaning can be completed with what we discussed earlier, which the PUI, or a final flush of a syringe. This is our choice. But from studies where PUI and regular syringe was used, it can be concluded that PUI is more effective in removing remnants of the pulp tissue and dentine debris and planktonic bacteria. So here is a photo showing us on the left side a photo of obturation wherein a regular syringe irrigation was used, and on the right side, this is the obturation where passive ultrasonic irrigation was used. So the significant increase in dissolving capacity of organic material by sodium hypochlorite is aided by your passive ultrasonic irrigation. So, and also, it could be that when you put your passive ultrasonic irrigation inside your canal, it also increases the temperature. That's why it could be one of the causes or one of the reasons of the increase in dissolving properties, dissolving reaction of your sodium hypochlorite inside the canal. Also, it was shown that the smear layer removal was also improved with the use of your passive ultrasonic irrigation. And passive ultrasonic irrigation can also be effective in curved canals. Here with the curved canals, you just have to pre-bend the tip below the curvature so that it would be more effective. It was also shown that in the isthmuses, there is much cleaner debridement using this device. And as I've shown you before, the passive ultrasonic irrigation is more effective than sonic irrigation. Here is another one, the Endovac system, which is by Discus Dental. It is a high-speed suction cannula. Endovac system is a new irrigation system that consists of a delivery system and evacuation tip attached to the syringe of an irrigant and the high-speed suction of your dental chair or your dental unit. So as the cannulas are placed in the canal, a negative pressure pulls the irrigant, a fresh supply of the irrigant from your chamber down into the canal to the tip of the cannula, and then into the cannula, and then finally out of the suction. So they have shown that endovac system and PUI and syringe at 3 millimeters from the tip from your apical from your periapical constriction. There's no much difference, but they compared it at the 1 millimeter area from the apical constriction. Endovac system seems to be more superior than the two other irrigation techniques. So another one is we go into the more advanced technology. I'm just going to say it so that we all know that this is available already in the market and it's being used by some specialists and some practitioners. So this is the photon-induced photoacoustic streaming. So debridement of the canal is using a proprietary laser energy at the subablative power levels. The laser creates a photoacoustic shock waves within the cleaning and debridement solution in the canal. And the containment of the shock wave streams the solution three-dimensionally through the entire canal system. So studies would show that this is also very effective. Passive ultrasonic irrigation and tips. So, well, obviously it should be more effective because it is much, much more expensive than our PUI. So, in conclusion, they really show that there is negative samples of bacteria and the removal of biofilm at the apical level of the root canal. Another one, this is the newest innovation in canal cleansing, which is by the company called Sonendo. It's a multisonic energy in a closed system. It works by multiple wavelengths of sound energy carried through the degassed irrigant safely and deeply into the dentinal tubules. It moves the irrigants through the entire canal system. Apparently, there is no extrusion, so it's very safe. And there is simultaneous cleaning of the canal. So if you have four canals, all canals would be cleaned at the same time. Imagine that. Okay, so and also they claim that minimal instrumentation is needed when you're using this system. So everything is like really getting more advanced, and maybe after a few years, the dentist will be rendered useless already. So let's just briefly touch on the intracanal medicaments. So intracanal medicaments is a temporary placement of medicaments with good biocompatibility into the root canals for the purpose of inhibiting coronal invasion of the bacteria. So with the advent of single visit endodontics where intercanal medicaments are not used, there is a question if it's still important in our endodontic practice. But because there are also various reports that have shown that single and multiple visit endodontics would yield the same amount of success rate. So, but if in some cases that we would need to do multiple visit endodontics, intracanal medicament is highly advised to be used. So, intracanal medicament, the most common one would be your calcium hydroxide, which has an antibacterial property. It can also dissolve bacteria along with its byproducts and toxins. It can dissolve necrotic tissue. It comes in a dry powder form, which you can mix with your saline solution, your water, or your anesthetic syringe. Okay, it also comes in a syringe form. Where it could be water based, and some products they come with barium sulfate, which would make it radio opaque. There is another type of calcium hydroxide in a syringe form wherein it is mixed with the iodo form, which is another antibacterial chemical. So with the use of calcium hydroxide, we should be very careful with extrusion, since extrusion into the periradicular tissues could cause tissue necrosis and also pain. Another intracanal medicament that is in the market would be your leather mix. Leather mix is a mixture of antibiotic and corticosteroid combination. So it is very helpful when the patient has pain. Chlorhexidine gel is almost the same as the Irrigant. This one, it comes in 2%, so you can also use it as an intracanal medicament. So let's we come at the end of our presentation. So we all know that bacteria is the major cause of the pulpal and periapical disease. So the complexity of the root canal system and invasion of the tubules by microorganisms and formation of smear layer during instrumentation and the presence of dentine are some of the major obstacles. So this one we could overcome some obstacles by using the proper irrigant, irrigant or combination of irrigants, which is our sodium hypochlorite, which is we know that it's the gold standard for irrigants, along with EDTA and chlorhexidine. We all know that passive, from the studies shown, passive ultrasonic irrigation is more effective than your regular syringe irrigation and your sonic irrigation. But there are better devices or techniques to do this, but it comes with a price. They are more effective. They are like big consoles and would cost tens of thousands of dollars for sure. So in the market, I think one sonendo is like 40 to 50 thousand dollars. So when it comes to the medicaments, it's when we use it, calcium hydroxide is the most readily available and easily utilized intracanal medicament. So with this, we would like to thank all the big companies for having a big budget for the research and development, and the search continues for the ideal materials and technique when it comes to our endodontic practices. So thank you. That ends my presentation for today, and I hope you learned a thing or two.
Okay, thank you, Dr. Kelly. I think you take a long time to spare to presentation for your PowerPoint, and I see some
Mhm.
future if we make course again. I want to see more case, your patient case. Then more dentists will know more about your technology to study from you.
Yes, yes.
Yeah, so now it's time for let me check the question. Let's answer the question. First, just now I already see all the comment. Most of them, they say like some many friends from Philippines. This time, I think you are very popular in Philippines. And I see just a little question. So I think your presentation already very clearly. You can see such some dentist feedback. It's very nice presentation, very great webinar. So I think this is a useful and interesting. And here is a great webinar. So just now I find out one question, Joanne. You can speak the question and then Dr. Kelly answer.
From Dr. Hadi Amar. Hello, doctor. What is the less toxic irrigation you recommend to use?
Less toxic irrigation. For this, we have to compromise. So, as I said, the gold standard for your irrigation techniques would be your sodium hypochlorite. Lowering the concentration would help this um, if you're not very comfortable with using the full concentration. What we can do is like there are other techniques to lessen the toxicity. So we can mix it at a lower concentration, but we can increase the temperature so that the and antibacterial activity and dissolving properties of the sodium hypochlorite will be maintained. But you also mix it. You also not mix, but you use the other irrigants in conjunction, as I said, so that we can get all the ideal properties of each irrigant. Do we have another question?
No, uh, just
That's
now
it.
my internet have a problem maybe.
Mm-hmm.
Okay, so I think everybody they say very interesting like that, but question very little. I think your presentation is very clearly. So check this
Thank you.
one. Joanne, speak the
Yeah.
question.
From Dr. Edita Fermeza. What is the best medicament for necrotic primary tooth?
Medicament for what I would usually use would be the calcium hydroxide for all of my cases. Unfortunately, I don't handle pediatric patients, but calcium hydroxide is a universally used intracanal medicament.
Okay, next question.
From Dr. Edita again. What is the best intracanal medicament for necrotic permanent molar?
It would be the same. My answer would be the same. The calcium hydroxide. It depends on the case. So as I said, your calcium hydroxide would come in nowadays. I don't use the powder form anymore. I would use the one in a syringe form. So this one would come in a water base, and the other one would have a silicone oil. So for my everyday intracanal medicament, inter-appointment medicament, I use the water base because it can easily be washed off with your usual irrigant. When there is like more severe infection, I use the one that is mixed with calcium hydroxide with iodoform.
Okay, so I think just all the question we check is very little question. So it's time for our next step. For I feel many our friends to waiting for this moment for our lucky draw. So this time we made the lucky draw is for 5 pieces of this end of five pieces.
Wow.
Yeah.
Yes.
Before maybe only one, but this time I make a prize for 5 pieces. So
Okay.
5 pieces of this end of file, and you can see our end of file here. This
Mm-hmm.
end of file is very short. Even you bend it much, it's not broken. So it can work very well, very safe, not broken, no need to worry to broken in the root canal. So this is our COXO file, and this file we use is nighttime file. It's nighttime material and with the net no clothing. So after you cutting much, if they release, you just need to put into autoclave or put the hot water. They will recover again. So this endophyte it can use it for many times. So now it's time for our moment to make the lottery. Wait a minute, let me share my screen. Okay, can you see my screen?
I can see the SC Pro slide.
Uh, Wait,
There
I
you
need
go.
to control to this.
Hmm. Hmm.
Now can see.
Yes.
Okay,
Tingnan na. Yung concern.
so let me choose this.
Sundo.
To see how many dentists common this time.
Didn't you come?
And then let's begin. Right? Okay, Dr. Kelly, please help me to count 1, 2, 3. Then we will choose this. Who is the lucky person to get this?
All right. All right. 1, 2, 3.
Okay, let's check.
I hope it's me. I'm just kidding.
Okay, Joanne, who is this?
The winner is Dr. Ike Orlina.
You
Oh,
feel
wow.
this
Yay.
name is from Philippines.
Congrats, Doc.
Congratulations to Dr. Ike.
You know this
Yes,
dentist?
I know him.
Oh, congratulations.
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 5 pieces this time. That's so great for we get 5 pieces of this end of five for this time. Okay, so today the webinar will be finishing. COXO webinar will be keep every week. Try to make the free course for all our dentist friends. So welcome to join our COXO webinar again. I hope our COXO dentists can be know more of technology and support our COXO product again. So thank you so much. Thank you, Joanne. Thank you, Dr. Kelly, today.
Thank
Thank
you,
you.
everyone.
Thank you, everyone.
Any comment you can leave message to continue, and then Dr. Kelly will try to check and answer later.
Yes, yes, I can do
Goodbye.
that. All
Goodbye.
right.
Goodbye.
Goodbye.
Bye.
Bye.